Hi, everyone. Welcome. I'm Erin Peterson, the Director of Mission and Partnerships for the Colon Cancer Coalition. If you're not familiar with the Colon Cancer Coalition, you may know us as Get Your Rear Gear, our event that we host in the Twin Cities, as well as in over 30 markets across the country annually. We're so excited to have you here. Thank you for joining us. I want to keep this welcome short. You can see the agenda next to us. We have a lot we want to cover. And we're going to get started, but first I have some housekeeping things that I want to talk about. The webinar is being recorded, and we will provide a link with the recording and some Q&A in a week, probably, maybe a little less. We'll get that out as quickly as possible. You can share with people that did not get a chance to log on, or if you want to revisit any of the information. We will be having a Q&A function or Q&A at the end of the presentation. If you have questions along the way, please use the chat feature in Zoom, and we will collect those and ask our panelists at the end. And then if you want to tweet along, please use the hashtags blue for CRC or MNCRC. We'll be following those along and doing some retweeting and engagement that way. That being said, I'm going to turn this over to my co-host, Matt Flory, and he can do our presentation.
Thanks, Erin. As you can see, I have a nice backdrop of fall color because I'm pretending that it's not going to snow today. Thank you, everybody, for joining us today. I'm going to talk a little bit about stool test recommendations during the pandemic, covering some of the ground from the National Colorectal Cancer Roundtable, but also teeing up some presentations from health partners and Allina Health, who have both had this conversation within their medical groups to share with all of you today. Erin, can you advance the slide for me? So as you know, as everybody's very aware at this point, the pandemic has had a pretty significant impact on cancer screening rates, predominantly because in the early stages, we encouraged people to cancel routine healthcare visits, and we had really suspended that. And that had a pretty significant impact. These are numbers and data from an April study that showed colonoscopies were down 90% year over year. Next slide. We also found in similar data, this is a JAMA report, that the diagnosis of colorectal cancer was similarly down in April, down by 49% for colorectal cancer. And that's not because there are fewer colorectal cancers, but just people were not going in for screening. So these missed colonoscopies and missed colon screenings are going to result in more of these cancers being found at later, less treatable stages. Next slide. And in fact, again, an April estimate was over 18,000 colorectal cancers will be either diagnosed in later stages or maybe missed entirely. Next slide. And again, a conservative estimate from NCI, this was in June. So as the pandemic has run longer, these are much more conservative. The real numbers are going to be larger, but 4,500 deaths projected between 2020 and 2030, just based on missed or delayed colorectal cancer diagnosis. So this is something both locally and nationally that public health and healthcare experts have been taking very seriously and talking about what can we do during the pandemic to keep cancer screening a priority and to start to explain to the public that we've had time to make adjustments and to make things safer. But with colorectal cancer, people thought there's a particularly good opportunity to expand on the options and to make it clear to people that are reluctant to come into to the office for care that stool tests are effective. And so that's what I'm going to talk about a little bit today. Next slide. So resuming colorectal cancer. And Erin, do we have a poll question? Can we do that quick?
Yes, hold on.
So just ask you guys to help us out here with one quick poll question that way I won't go too quickly or move too slowly through the content, but also to give all of us a sense of who's on the call. So have you changed your approach to screening as a result of the pandemic? And the first option is that you're already promoting stool tests before the pandemic came. The second is that you started promoting stool tests during the pandemic. And the third is that you're considering the promotion of stool tests because of the pandemic. So Were you already doing it and you're just looking for a brush up? You started to do it and you're in the process, or you're in the planning phase? We want to just give people a minute or two, Erin. Does that sound okay?
You tell me when you're ready to end it.
I think that's probably good, because it's a pretty simple question, right? Where do we come out? We have 58 participants, and some of us are panelists. Oh yeah, so we still got a pretty good vote. So most people were promoting stool tests before the pandemic. That's great. But we do have a couple of people on the call that started to promote stool tests, and a couple people on the call that are planning to do that or considering that, and that's great. As Erin said, the call today is being recorded, so if you find that this is good information, we please encourage you to please consider sharing it with your peers and let other people know. Erin, can you move past the poll? Or close it down there, great. Next slide. So this is a slide that shows some of the early data that demonstrates that cancer screenings are rebounding as clinics were able to safely reopen. People were coming back, but they're not rebounding fast enough to make up for the decline. And so we don't have data, at least national data, much less local data, more recent than that sort of April and June data, but these trend lines don't look promising. We still imagine that we're quite a ways behind where we could be or where we should be for colorectal cancer screening. Next slide. So certainly some significant challenges, as many of you know. The most pressing one in the short term has probably been working through the backlog of patients who were scheduled for procedures and needed to reschedule them. New protocols for cleaning and social distancing, the fact that there's variability in different communities, and even frankly in people's individual practice about what's going on with COVID infection rates. That's especially early on was a problem in terms of projecting national messages, but even increasingly people understanding that rural counties have as many cases as urban counties, that trend has shifted some. Patient fear, reluctance, and confusion is maybe something that is going to linger even beyond the pandemic, that we have to think about new ways to get people who are reluctant to get screened. Complexities of the shift to telehealth, so that some patients are maybe having the advantage of seeing their doctor through televisits, but then there's not the opportunity to do in-clinic procedures. Decreased primary care capacity, loss of employment, both for people that maybe have lost their insurance, but even, as we said, that primary care capacity if people had to lay off or furlough people. And longstanding inequities are likely to get worse. Next slide. In terms of backlog, certainly a lot of people on this call may already be working on this, but the need to do some prioritization to make sure that if you have limited capacity, fewer appointments available, that you really focus on following up with those patients who are symptomatic or maybe at higher risk due to personal or family medical history. High-risk patients in particular should be prioritized. And so in some parts of your state, there may be lots of capacity to offer colonoscopy as a screening option. In other parts of the state, there may be limited capacity. And so, just a general recommendation to try to prioritize and make sure that symptomatic patients or patients at high risk get colonoscopies for sure. And the potential to use stool tests as an option to relieve some of the burden or some of the pressure on those limited schedules, but also to give patients a choice. Next slide. I think we're increasingly trying to figure out what's the best way to talk to patients about safe screening. I think generally at the Cancer Society, what we're trying to do is include messaging to encourage people in the public to know that we've had some time, the clinics have had time to make adjustments, and to try to place some just basic questions in their head that, if they are concerned, that these are things that they should be able to ask with relative certainty, to make sure that most facilities are checking everyone for symptoms. Everyone in the facility, including patients, should be wearing a mask. The facility should do everything possible to keep social distance. Waiting rooms shouldn't be crowded. And some endoscopy centers may even require pre-procedure COVID testing. So these are these are general things that, general questions we're putting out into public conversation, and maybe a place where in some of our states we should be talking to each other to see how can we sharpen this messaging, how do we work together to communicate things so that people are hearing both from their physicians and from third parties like the Cancer Society or the Colon Cancer Coalition, you know, messaging that fits together, that resonates together. So we're all working together to assure patients that there are safe opportunities for screening. Next slide. But as I said before, early in the pandemic, the National Colorectal Cancer Roundtable, which is a coalition which includes the American Cancer Society, the Colon Cancer Coalition, the CDC, a number of the health insurance companies and health systems on this call today, really saw an opportunity to move maybe a little faster with colorectal cancer because of the opportunity to promote stool tests, tests that can be done in the privacy of your own home. Next slide. The Colorectal Cancer Roundtable pulled together an expert panel on stool tests to develop sort of a playbook and really some guardrails and some guidelines, some suggestions for providers about what they could be doing to establish you know, programs or maybe make the shift for those groups that maybe weren't doing as much proactive promotion of stool tests. So I'm going to go over that a little bit quickly. They published this playbook in June 30th of this year, and they did a webinar on July 23rd. Next slide. Just going to highlight some of the overarching pieces. Certainly anybody that wants to get a copy of the playbook, we can find it online and get you that web address. But the main things that we're going to talk about today are really the opportunity for people at routine risk to be offered the choice of stool tests as safe and effective tests to screen for colorectal cancer. These tests include stool tests, the immunochemical test FIT, FOBTs, but also stool DNA tests. All of these are good tests that have been shown to be effective at early detection. The other one is that, just sort of reiterate, which I already said, that for people that are at higher risk based on family history or personal medical history, we don't want them to not get colonoscopies. It's just that for people at average risk, stool tests are an option, and that we want to also make sure that there are available colonoscopies so that anybody that has a positive stool test or stool DNA test can get a colonoscopy as quickly as possible, a diagnostic test. The other points here, primarily just, you know, that deliberate focus to address disparities and the need to do some collaboration. Next slide. As you can see, just a quick side-by-side comparison of ACS and U.S. Preventive Services Task Force guidelines, just to point out that stool tests and stool DNA tests are in guideline for both of them. They are part of the HEDIS measure, so they're covered by health insurance, and that those, while there may be some differences of opinion about whether screening should start at 45 or at the age of 50, the actual tests we're talking about, there's consistent agreement between public health experts and healthcare experts that all of these stool tests are great tests. Next slide. In fact, here's a quick bar chart comparing FIT FOBT with colonoscopy or flexible sigmoidoscopy and FIT, and it shows the efficacy of these tests side by side is very close in terms of the number of colorectal cancer deaths prevented per 1,000 people screened. So highly effective, stool tests are highly effective at catching cancer early enough when it can be effectively treated. Next slide. The National Colorectal Cancer Roundtable Playbook in Statement 5. So, you know, I'm not going piece by piece through the playbook, just highlighting the pieces that I think were most relevant for our discussion today. Really, during a time when availability of elective screening colonoscopy may be limited by the pandemic, we're just suggesting that screening can be safely offered through at-home stool tests. So several safe, effective tests. Stool tests are convenient for patients, especially in areas where there's high COVID prevalence. So not just in terms of where we've been, but maybe where we're going, that stool tests may be increasingly a better option, regardless of colonoscopy and endoscopy access, but especially if you're in an area where it's harder to schedule these tests, or whether there are going to be fewer colonoscopies available because of social distancing and cleaning requirements. something to consider. Vast majority of insurances cover tests. The test can reach those living in rural or hard to reach places, especially through mail. And we're going to talk a little bit about mailed colonoscopy. A positive abnormal test must be referred promptly for colonoscopy. So we just want to make sure that we're not, that nobody is just offering the test, but they have a clear plan in place for how to get those tests back and how to make sure that there's great follow-up so that anybody with a positive test does go on to get a colonoscopy to see if they have cancer. Next slide. So here's just a quick view images of the different tests. People are pretty familiar, I think, by this point with the FIT test as a single sample, or most FOBTs, which are 2 or 3 samples. We also have a picture here of the multi-target stool DNA test, which commercially is known as Cologuard. These are all effective tests, all in guideline, all great at catching cancer early when it's easier to treat. Next slide. There's a great simple handout from the National Colorectal Cancer Roundtable. It's about 4 pages. They update it every couple of years, which allows you to compare these tests side by side. That's also where I pulled the bar graph about the efficacy in terms of colon cancer deaths averted per 1,000 screened. You can't read the individual detail, but again, if you're looking for this document, we're happy to help you find it online. It's a great tool, not just for people that are just starting out, but people that maybe want to revisit the test that they're using and just either reaffirm that you're using the test you want, or just check out maybe what's newer on the market. And this is just a great simple summary. It's footnoted, but a good executive overview that allows you to compare the tests. Next slide. In terms of deep dive, like I said before, consistent information, and actually there's far more reports and documents at the National Colorectal Cancer Roundtable website about how to set up a program so that you're not just distributing the tests, but you have a good plan in place for getting the patients to actually return these tests to you and to follow up with them. So it must be considered a program, not simply a test. System should be in place for ordering and distributing the test, making sure it gets done, obtaining results, acting on both positive and negative results. Both FIT and the stool DNA test must be ordered by a clinician, most commonly the patient's primary care clinicians, although the test can be ordered through urgent care centers, retail clinics, or independent telehealth providers. And I think it's always better to have a primary care physician in the loop that can help make sure that patients understand not only the importance of doing the test, but follow up to a positive result. Prompt referral to colonoscopy. This is actually a bigger problem than some people may realize, although we're talking to providers, so I think many of you do realize not everybody that has a positive stool test or stool DNA test does go on to get a colonoscopy. And those are people we really want to make sure get in for treatment as much as possible. We want to require close communication between primary care and GI practices, especially if you're referring to people outside of your practice, that you have a good conversation with them about how things are going and can, just keep in touch with patients as tests are coming in. And a positive test without a colonoscopy in most professional circumstances is really considered an incomplete screening round. So we need to make sure that's in place. Next slide. So this is just a quick example of a way you could demonstrate the workflow graphically and sort of figure out how your clinic workflow process is set up. How's the FIT offered? What % of the FITs were complete? Were the positives referred on for colonoscopy? The FITs that were negative, how do we put those patients into a file for a regular follow-up, since the stool tests are an annual test, or the Cologuard test would be every 3 years. So we don't lose track of people going forward, and we keep them up to date a little bit, since there's just a little bit more requirement for follow-up if you're using stool tests. Next slide. So the National Colorectal Cancer Roundtables are to discuss with your patients that stool-based tests are important and effective options for colorectal cancer screening. This recommendation was actually a strong recommendation even before the pandemic. We did lots of focus grouping at the Cancer Society and the National Colorectal Roundtable that found that the opportunity to choose an option resonated well and helped move many practices up, but even more important right now, to reinforce that stool tests are safe, even in areas of high COVID prevalence, to understand how FOBT, FIT, and multi-target stool DNA tests are being conducted, in the environment. So even just understanding what other people may be doing in your community can help us provide better messaging and more consistent messaging. I think a pandemic is a time when even clear communications can sometimes get garbled. My children are in hybrid school, and our school district keeps making little changes. And even when the school district communicates something clear to us, other parents will ask questions based on how they read something, and communications that used to be clear are suddenly less clear in this sort of pandemic world where there's a little bit more stress. So I think as much coordination as we can do, we should do as much coordination as we can do. Develop tracking and reminder systems. Probably most people on this call have that kind of stuff in place, but it never hurts to revisit them. Establish and maintain close communication between primary care and colonoscopy practices. Next slide. Just wanted to touch briefly on stool DNA tests because those were newer addition in the 2016 guidelines, and there have been a number of publications out there that are worth reviewing. If you're considering that test, it does have slightly higher sensitivity and specificity, which does result, which is one of the reasons, frankly, that it's a test that's offered every 3 years. It's a test that offers both. It both looks for blood in the stool, but also DNA. Next slide. The original New England Journal of Medicine article is still worth looking at. This is really the publication that put this test forward, and when it was accepted into the guideline. Next slide. And again, that primary reason, this is just a quick bar chart look from that publication, is that those stool DNA tests are finding colon cancers, those late stage colon cancers, at about the same level as traditional FIT and FOBT tests, but they're a little better at finding earlier cancers, so stage 1 and stage 2. And that's why it's a 3-year test instead of an every other year test. As a result of some of that increased efficacy, there is a slightly higher rate of false positives, but just wanted to present this information. You can actually find the publications again. If you want help finding these, certainly contact us after the call. Next slide. There's another recent study in the preventive medicine reports that actually shows that there's slightly higher, or actually a much higher rate of follow-up colonoscopy scheduled after a positive stool test. And this may partly be based on the types of practices that are choosing to use stool DNA tests versus FIT tests. It may also be based on the fact that some groups are great at doing follow-up for FIT and other groups are not as good at doing follow-up for FIT tests. Whereas with stool DNA tests, in many cases, the company is doing the follow-up. So if you work with Cologuard to do that follow-up, it's consistent over time, whereas people that are using FIT, some are good and some are bad, and the average is a little lower. Again, this is a recent publication. Happy to help people find it if they're interested in it. Next slide. So want to talk briefly about a couple of national case studies and then turn it over to some Minnesota medical groups to talk. Next slide. This is a health point case study that comes to us from the CDC. It's about primarily the mailing of FIT tests, but it also acknowledged that they did do some FIT distribution through flu clinics and through mobile mammography events. Next slide. And what I wanted to highlight in particular is the high return rate that they were able to get. So even if you have your existing program is returning, is distributing stool tests and getting some back, I just offer this as an example that the CDC held up, 31% return of mailed FIT kits. And my question is, what is your group getting? And that's not to suggest it's not doing great. 25% is good. Maybe you're doing better than this. This is a good benchmark. It's held up by the CDC as a national one. And they're getting a 31% return rate when the average cost of implementing that intervention per kit returned is $18.76. The average cost of the total intervention is $40. So this gives you some general ideas of a benchmark. Maybe you're beating it. Maybe you are doing good, but have some room to improve. And I think that's one of the things that we want to do on calls like this, is not just provide information to people that haven't started, but that challenge or that benchmark to see, is our part of the country actually ahead of other parts of the country? And we often actually do find that Minnesota, Wisconsin, the Dakotas, that we do provide a little higher value than we get credit for on the East and the West Coast. But this is a benchmark place to start, and it shows that mailed fit can not only be effective, but cost effective as well. Next slide. Kaiser, I think this is pretty well known, has been doing mailed fits for over a decade or so. I just wanted to point out that they do have, if you haven't done mailed fit programs before, they do have kits online that sort of explain the process, and a lot of that is readily available in the public sphere. Next slide. I also wanted to point out that there are a number of great, not only examples where an intervention distributing stool tests through flu clinics have happened, but it's a well-published evidence-based intervention. I think they're going on 9, 10, 11 publications in multiple settings. It's likely too late to consider that this year, but maybe something to consider for the future. And again, this FluFit website has a lot of the tools and background you need available all in the public sphere. Happy to help people find any of this information if you're interested. Next slide. So here's where I want to transition from that general background. Hopefully it wasn't too much review and maybe provided a little bit of new information for all of you. But I wanted to start by asking Greg Fedio to talk a little bit about Health Partners and what Health Partners has done with stool tests. And then we're going to ask Tessie Ross to talk a little bit about Alina. Can you take it over from here, Greg?
Yep. Can you hear me okay?
Yes, you're great.
All right, great. All right, well, thank you for having me here today. I'm just going to go over quickly what we have been doing at Health Partners on both the care group side, but also the plan side. I know my counterpart from the plan side, Sylvia Bobbitt, is on the call, but so I'll be speaking for her. But maybe if she has any comments, she can put that in the chat. So on the care group side of things, we're sending approximately 7,500 kits out by the end of 2020. These patients were identified through an EPIC reporting workbench. That's the tool that we use in EPIC to help us identify our never screened population. So from that never screened population, which is, and we have a couple different care groups when I say Health Partner. So it's Health Partners Medical Group, it's Park Nicollet, it's the Amory clinics, and that's also including our Stillwater Medical Group. So each of our organizations has a reporting workbench where we can identify these never screened patients. So just a quick example on the Health Partner side, it's about 10,000 patients that show up on that list. It's about 11,000 on the Park side. So we whittle that list down then to try to identify this population that we want to send kits to. So one of those things that we have in that reporting workbench is we are able to identify contraindications. So if they have something in their problem list, like history of polyps or ulcerative colitis, things like that, that should exclude them from getting a fit kit, we have that built into our reporting workbench where we can eliminate or not send a kit to those patients, if that makes sense. The other thing that we want to do is we do have active GI departments that are doing colonoscopies. And of course, during the time of COVID, they took a hit, right? And we also want to make sure that we are getting those patients in that need colonoscopies. So if anybody has an active order for a colonoscopy in that, we have that identified in our reporting workbench too, so we don't send a fit kit to them. Again, our perception is that those patients had a conversation with their provider about getting a colonoscopy. They have an active order. We're not going to send them a fit kit. We've done a lot of fit outreach in the past, so if they have done if they've gotten a fit kit in the past, for at least for this round of outreach, we also did exclude those patients. Obviously, we have the opportunity to reach out to them in the future, but for this one, we wanted to target really those patients that have never been screened and that have never gotten a kit in the past that didn't return one. Our patient population also includes Black and Indigenous patients starting at the age of 45. So that is something that Health Partners has always stood behind. So for our other populations, we start at the age of 50, but for Black and Indigenous patients, we do start at the age of 45. So we're kind of a melding of that American Cancer Society recommendation and the USPSTF. So this had been work that had been done by the clinic team. So our 50+ clinics, when they have the opportunity to work these reporting workbenches and send these kits out to patients. But obviously during the pandemic, it's all hands on deck doing other things. So this was work that they couldn't get to. So throughout the year, we didn't really have our normal fit outreach. So that's where a lot of these patients are coming from, right? They had been patients that we might have reached out during a normal time, but obviously during COVID we didn't have the time, so we reached out to them in mass at the end of the year. We are looking at centralizing this work ongoing at the lab, at the central lab, but again, during the time of COVID, there's other work to be done. So as part of this, we did this new outreach, or this outreach this year, we did include new messaging specifically around COVID, talking to patients really about, you know, we want to keep you safe, and we can keep you safe in this time. You've never been screened for, our records show that you've never been screened, but it's important to do it, and you can do it from home. Here's your kit. We also did a couple different things from other previous outreaches. We have a new patient education material that we included that was a little bit more, you know, what do you expect with this kit? You know, not necessarily instructions, but more just explaining what this is and what colorectal cancer screening is. We had in our previous outreaches also included a pre-letter. So the process was pre-letter, then the kit, and then a post letter if they don't return the kit. During this time, we eliminated that pre-letter and just, you know, included that the letter explaining the kit, the patient education material, and kind of that COVID messaging with the kit right away. So these kits are, half of them have been sent, or more than half have been sent. The next batch is going to be going out in the beginning of November. So I don't have any results yet in terms of our return rate. Typically, we see about a 20 to 25% return rate. And with the changes that we've made, we're hoping to get that to closer to 30. And again, we will be doing those follow-up messaging to patients that didn't return it within the first month of getting the kit. All right, the next slide. So again, I'm speaking for the plan. Oh, actually, no, I did want to hit a little bit on the things that we've done for colonoscopy too. I know we're focusing on stool samples, but we also did send Epic MyChart messages and letters when our GI group started opening up again and needed help in terms of getting you know, their slots filled basically, and helping patients recognize, especially those high-risk patients that did need to come in for those colonoscopies. We actually have had some success by using a message that, you know, around keeping people safe during the time of COVID. We know it's a concern, but we can keep you safe, and you need to get these tests. And we're seeing about a 15% conversion rate on our letter outreach around colonoscopies. And we actually have started doing outreach again to the average risk population. So again, this is identifying those patients that we started with, those high risk. So anybody that needs to come in, you know, the 2 or 3 or 7 years, so less than that 10 years. And we have expanded it to that 10 years. And again, we're seeing about a 15% conversion rate. So this is again, that population that can't do the fit. But I think the message here is really, if you're specific around trying to let the patient feel comfortable or safe during the time of COVID, we are seeing some success in getting people back in for those tests too. And then our plan side of things, they sent about kits to about 20,000 members in 2020. So there's 2 different populations, the unattributed patients and then the Medicare population. Their overall return rate is around 15 or 14.5%. However, the Medicare population return rate is around 24%, which is higher. I talked to Sylvia yesterday. That is higher than what they've seen in the past. So again, there is some we're seeing some anecdotal evidence to suggest that during the time of COVID, people want to test like this. Were able to get the test out earlier due to the pandemic, and they're offering support to care delivery groups to manage FIT programs as well. So some of the care delivery groups that they worked with. And they also did start including some messaging about COVID in October and November reminders. So I'll be around for questions at the end as well.
Thanks so much, Greg.
Thank you.
Tessie, are you there?
I am. Can you hear me okay?
Sounds just great. Thank you.
Great. Thank you for having me. My name is Tessie Ross, and I'm representing Allina Health Group today on our call to talk about our approach to offering stool-based testing more regularly in our primary care clinics during the COVID-19 pandemic. I think more than ever, it's super important that we're connecting our patients to the right care at the right time and in a safe and reliable way during a pandemic, because there are just additional concerns that our patients have, and that we want to make sure that they're feeling loved and comforted throughout the process, as well as, you know, offering the different screening methods. So next slide, please. One of the first things that happened early on in the pandemic was our leadership team, specifically some of our physician leaders, brought together a group to start having conversations around, you know, how do we be more thoughtful around our patients' needs during the pandemic and how that relates to colorectal cancer screening. So early on, we determined that there was a necessity for us to communicate out about stool-based testing and the benefits that that method may have for our patients during those early months of the pandemic. So we started with sharing information on the why. And so first of all, is really just reinforcing the recommendations that are out there related to the USPSTF, and that, you know, there are numerous screening tests that are out there to detect colorectal cancer, and the research out there has found that there are no head-to-head studies demonstrating that any of those screening strategies are more effective than others, although they do have varying levels of evidence supporting their effectiveness, as well as different strengths and limitations. So it's important to just reinforce that the best test is a test that gets done, specifically in the pandemic environment when people are potentially hesitant to colonoscopy. Next slide. We also decided to share some additional context about some of the advantages to stool-based testing in the pandemic environment. So this is a list of different, you know, indicators that we did share with our primary care teams, and that we also received feedback from our patients. So the first one was on physical distancing and convenience. Obviously, stool-based testing is more convenient because it can be done in the home, and we can mail kits to our patients as well, and they can mail them back. Patient preference, we were hearing many reports from our patients that they weren't comfortable having a colonoscopy, they did not want to come in, but were open to stool-based testing. From a capacity perspective, we wanted to make sure that we were connecting the right patients to colonoscopy access who were at high risk and really needed to have those services done. And then COVID-19 testing, you know, initially early on in the pandemic, that testing was limited, and stool-based testing strategies do not require a COVID test prior to, and so that was one of our efforts for conserving testing. And then personal protective equipment. We were very intentional early as well to ensure that our providers and staff have enough consumable PPE, and that all of our sites were supported in that way. And so obviously at home, when you're doing that stool-based testing, there's limited PPE because there's no staff involved. However, you would hope that our patients are doing that in a clean and effective way. And then procedural staff. So we also know that early on in the pandemic, we were talking about having staff be available to backfill other units and staffing areas like ICUs and ERs. And so we wanted to make sure that we had enough staff available for those high care units if more COVID patients were to come into our hospitals. Next slide. So two main interventions that we had were, one, we offered stool-based testing as a primary CRC screening method to average risk patients. And we took the American Cancer Society algorithm that was developed a few years back and enhanced that to include that messaging. And that would occur in-person as well as virtual visits with our patients. And then still encouraging that high-risk patients should have that shared decision-making and consider colonoscopy for their primary screening choice. And then our other decision was to expand our annual IFOBT mailing beyond the never been screened population to also include our patients that were overdue for stool-based testing. And we did apply appropriate exclusions, many that Greg already shared with us earlier. Our program, we did send over 40,000, we're in the process of sending out over 40,000 kits, and currently have about a 20% return rate, but we have not completed our full recall or our health equity strategies yet. Next slide. Thought it would be helpful to share a little data. So this slide really just reinforces everything that Matt presented earlier. And then the next slide shows our data at Allina Health. So you can see here, we started out just under 75% at the beginning of this year. And then throughout the early pandemic months, you can see the same decline that everyone is seeing. And then we implemented our efforts related to stool-based testing in July, specifically our IFOBT mailing intervention. And you can see since that time, we've increased almost 2%, which is over 5,000 patients have been screened through our focus on IFOBT testing and mailing. And the other thing to note is we did see a 2% increase in just that testing method. So our colonoscopy and FIT DNA volumes remain constant. So we do know that a lot of it was related to our mailing initiative. Next slide. So our next steps are to finish out our mailing and then continue our recall. We know that's such a huge part of the program, is making sure that we're connecting with our patients to identify maybe why they haven't turned in their kit and help them to overcome those barriers. And then we want to finalize our program results, which will include a significant amount of data on kits sent and resulted, our positive rates, our follow-up colonoscopy after positive rates, and then our health equity breakdown of those not returned. Once we analyze that data, we're looking for a health equity outreach strategy as well over the upcoming months, where we can look for those disparities that emerge and potentially outreach patients that potentially could use a call with a translator to talk a little bit more about that FIT kit that was sent to them, or the IFOBT kit, and provide some additional information, as well as send out a second kit if necessary. And I think that was my last slide, so thank you.
Thanks so much, Tessie. And as we will have questions sometime at the end here for if people have questions for both Greg and Tessie. But Aaron, I think we should wrap things up. I just wanted to make sure to note for anybody that's interested and potentially available that the National Colorectal Cancer Roundtable is putting their national meeting virtual this year. So as you can imagine, this used to be a invite-only meeting. People had to travel to the Washington, D.C. area, the Bethesda area, to attend in person. The program is available online. It is free, and it's accessible virtually. So maybe there's a session or two that you can make time for if you can't attend the whole thing. But you can find that at nccrt.org. You can actually see the web address there on the slide. But again, if you need help finding that, I have been assured they have more than enough lines that if we publicly promote this, we're not going to crash their site. So fantastic meeting that will have presentations like the ones you heard today from all over the country. Next slide. So I think these are your slides, Aaron, and then we'll go to questions and answers when Aaron's done.
Yeah, so if you have questions for Matt or myself or Greg or Tessie, feel free to put those in the chat box, and we will, we do have time at the end to go through those. So I just want to quickly go through some things as we start talking about generating screening awareness within the public outside of health plans, some of the work that the Colon Cancer Coalition does and that you can be a part of. So we have a library of awareness materials available on our website, and we do provide these, a small amount of these free of charge to our partners, but do make them available as well for co-branding or larger quantities ordered. And we'd be happy to have conversations with you about that. We do have the 6 postcards are available in English or in Spanish. The 2 trifold brochures on the right-hand side are available in 5 different languages. 2 of them are available via hard copy. The rest of them are available for download on our website. So those materials are available as you start thinking about doing health fairs again, putting colorectal cancer screening information in your waiting rooms, using that for patient education within physicians. All of these materials are available, and we'd be happy to have conversations about either providing them for you or doing some co-branding as well. And then we also know that the spring is going to look different. The Colon Cancer Coalition specifically, we do a lot of in-person awareness events. So we know that first quarter may look very different. So as we look at March coming in Colorectal Cancer Awareness Month, I know it's 6 months away, but we are already starting to plan. We are expanding the program that was started here in Minnesota with lighting blue landmarks and creating a night, or expanding it even to a week or the entire month for generating colorectal cancer awareness, both in Minnesota and across the country. Here's some examples of what we have lit blue from the East Coast to the West Coast to the South, as well as some Minnesota examples. We will be looking for partners in this initiative as well. Look for that to come. But those are just a couple ways that you can get involved with the efforts that the Colon Cancer Coalition has to raise that awareness about screening, saving lives through this preventative test. We'll now open it up for questions. Rachel had a question about the languages that we have available. We have English, Spanish, French, Chinese, Korean, and we have one of them available in Somali and are working to translate the second. So that would actually be 6 once we get that second brochure translated. But really that's the only question. Are there any others out there? Feel free to type them in the chat box. Matt, Greg, Tessie, anything you wanted to add?
I just want to thank everybody for making the time today for the presentation. We hope that it was helpful. I think, Erin, we will have an evaluation for the webinar. Is that right?
Yes, we'll do an evaluation that will be sent out with the link
Great.
For the slides and the replay as well.
And Greg and Tessie, really appreciate the Minnesota examples from Health Partners, Medical Group and Health Plan, and from Alina. Hospitals and clinics. I think those were helpful. We're always looking for additional stories. So if you think, hey, we do that, don't hesitate to reach out to me. I think we will be looking to do more webinars, especially as the pandemic continues, to talk about how, basically so our clinics can continue to compare notes. Erin, I do see an additional question that just came in about where people can download and print the slides. Are you going to be able to post those on your website, or should we just email those out to folks? I don't know how big the file is.
We'll post the link for the replay as well as the slides on our website. So once we have all of that set up, the link to that page will be sent.
Enough images that it might, I'm assuming if we emailed the slides out, it might bounce off a few. So
yeah, it's a pretty large file. Yep. So we'll create a download on our website and send that link when we have the webinar replay ready to go.
But if you have thoughts, even if there's something that you think, if you think there's something else you'd like to hear about, one of the other ideas we talked about for future webinars is talking about donated care for the uninsured. I think we do have a couple of presenters lined up to talk about donating colonoscopies for the uninsured. Both a Minnesota model, but some models from other parts of the country. So you will see some information about that. But in addition to giving us feedback on this webinar, if you think of other topics you'd like us to add, happy to do that. We did get a question in here about whether we're able to offer CEUs, and we're not able to do that for today's webinar, but we will look into that for future webinars, just finding a professional partner so that we can offer that up for nurses or others that are looking for CEUs. Anything else? The website is coloncancercoalition.org. Is that right, Erin? We'll send out a specific link.
Yeah, we can make sure that that link goes to all the registered participants or the registered attendees for this webinar. And the Colon Cancer Coalition will put it out on our social media as well once it's available. There'll be a specific page in our website for that. It won't be on the homepage.
Great. Thanks everyone for your time. We'll give you a little time back today. Hope you have a great day and stay safe.